Amazing.
So, yeah, I'm Becky. I'm the unit training lead. So if any of you decide to join the St John Ambulance unit, then you'll be seeing a lot more of me. And then Beth.
I'm Beth. Hi, I'm the society training lead. I am meant to take a lead on all of these sessions, but this one has been very lovely, Lily, put together by Becky, because I've had a manic week. So it's going to be great. None of my boring slides.
Oh, sad. Right, so as you can see, we're doing primary and secondary survey. Some of you who've been to our fresher sessions might already have gone over this, but it's come up a few times in the last couple of weeks, so we just thought we'd go back to it, add in a couple of little bits as well. So if you have seen this before, at the end there's some fun things that you might not have done. Informal training, so this doesn't qualify you in first aid, it doesn't leave you with a certificate or any kind of qualification. It's just so that you've got more of knowledge and understanding, really. Yes. And Beth, wellbeing.
Oh yeah. So in terms of wellbeing and mental health, sometimes we cover some more distressing topics. It just comes up with the nature of first aid, unfortunately. If at any point you do feel uncomfortable, absolutely feel free to leave. No questions will be asked. Alternatively, you can just mute us and turn your screen off and walk away. It's cool, we don't mind. If you want to talk to anyone, committee are lovely, they don't bite, so feel free to chat to them. But if you specifically want to talk to someone who knows a little bit about the welfare system at the university, or you want to kind of chat at all, let me know. I am the welfare officer. But yeah, everyone's a happy face, friendly face. Just chat to us.
Yeah, and if there's anything in a session that you kind of might want to talk about, maybe pop a message to the EUFAS Facebook page and somebody will hopefully be on there to answer.
Or during the session, pop a message to one of us in the chat.
Awesome. So we'll go over primary survey, secondary survey, and then with the secondary survey we've decided to put some OBS in because I don't think we've covered that in freshers. So yes, exciting. The primary survey. So the primary survey is the first thing that you're going to do the minute you even, when your spidey senses start tingling and you think, oh my God, someone's fallen over, you're going to use the primary survey to assess the situation and find out if there's any life-threatening conditions. So it just kind of prioritizes sort of the life-threatening bits over kind of things that might not be as life-threatening. I tried to think of a different word for life-threatening, it didn't work. So we use an acronym. We use lots and lots of acronyms. This first one is Doctors AB, and that's for danger. So there's lots of kinds of danger you could come across, from cables on the floor that you could trip over to waterfalls that you could get lost in. I don't know. There's lots of different types of danger. If you're uncomfortable or uneasy, or you think you might get hurt, don't approach the scene, because 2 casualties is worse than 1 casualty. If you became a casualty as well, then we're all, a bit doomed. So to assess for CBRNE dangers, we use something called step 1, 2, 3. So CBRNE is chemical, biological, radiological, nuclear, and explosive things, which are bad. And if there's 1 casualty on the scene, you can assume that this isn't a risk and you can approach as normal. If there's 2 casualties, you might want to approach with some caution, because if the same thing's got them, it might also cause you some danger. And then if there's 3 or more casualties, do not approach the scene. In this situation, you would assume that there's a CBRNE risk and you're going to want to call the emergency services and wait for them, and don't go onto the scene. So yeah, there's lots of danger, but once you've eliminated any possibility of danger, you can move on to checking the response of your patient. So this uses another acronym that used to be really nice to say, but now is ASVPU. So that's for
your pronunciation changes every time you say that, and I love it. Yeah, it's so good.
It changes every time. So A stands for alert. So this is if your patient is aware that you're on scene, they're kind of aware of what's going on around them, they can kind of freely talk to you and don't seem too sort of confused, and are aware of kind of minute things happening around them. The next stage is confused. So this is a slight sort of decrease from that alertness. This is where they might not be as quick to respond to you being on scene or as kind of aware of the small things around them. They might not be kind of fully making sense when you're talking to them, but they're still able to talk to you. But they might just seem a little bit off. This one's kind of, the fine line between those two is a bit of an instinctual thing. If you think they seem a bit confused and a little bit off, maybe just say, okay, this person might not be fully alert. After that, we have voice. So this is when they are responsive to things you are saying, but not aware that you've kind of approached the scene before you started talking. So it might be that if you lean over them and say like, hello, can you hear me? I'm a first aider. That they kind of grunt back at you, that would be responsive to voice. Pain, so this is where we're going to get quite alarmed if they're not responding to your voice at all. So you've said, hello, I'm a first aider. Is there anything, can I help? And they've not said anything, they've not moved, not like opened their eyes. You would then give them 3 firm taps on the shoulder. You can also squeeze traps, but this isn't as advisable. It's just 3 firm taps. And then also with a baby, you can stroke the back of the heel, the back of the foot. And this hopefully will elicit a response. If it doesn't, we move on to our final stage, which is unconscious. And this is when alarm bells are ringing. You're definitely going to be kind of moving on to the next stages of treatment, which we'll get onto in a second. But yeah, so unconscious, they're not responsive to 3 firm taps on the shoulders, to your voice. They're just out cold, pretty much.
Yeah. Just kind of a point to add, response is kind of one of those things, it's one of our observations. It's something that we'll kind of be doing repeatedly on patients as we are treating them. So patients can move between the response levels, and kind of, in my opinion, it's easier to tell on the like confused is hard to tell point. It's easier to tell if somebody is confused based on like a decrease in their responsiveness. So if they've started as like alert and absolutely fine, and they're like able to tell you everything that's going on, and then kind of as you're treating them and as time is going on, they're getting kind of less and less certain and more, it's an easier it's easier to distinguish. So it's kind of one of those things that you're revisiting. Hopefully your patient the entire time is going to be alert, but they can move up and down this kind of sliding scale.
So monitor it continuously. So in Dr. Sabi, there is an S. So the S stands for shout for help. So this could be calling an ambulance. This could be calling bystanders to your aid and like getting them to kind of help you out and call the ambulance for you. But basically, you know, if you think you need help and if you kind of don't think you can deal with what's in front of you, that's absolutely fine. We aren't all Superman. We can't all fix everything. So shout for help, get as much help as you need, you know, call that ambulance, just so that you kind of remember to do that early on, so that if they are unconscious, if they then stop breathing and need an ambulance, you're really kind of on it in terms of getting that help that you need.
Yeah, definitely. Okay, so airways are the next thing that we're doing in our Dr. AB. So we're going to go on and make sure that the airways are both open and clear. If we have kind of a patient who has a decreased level of responsiveness, so potentially they're unconscious, a way that we can check that this airway is open and clear is by doing a manoeuvre called the head tilt chin lift. So you pop your, that's okay. So you pop either kind of like 3 fingers on their forehead or your hand on their head, and then a couple of fingers underneath their chin, and literally as it says, you're going to head tilt chin lift. And what this does is it prevents the tongue from obstructing the upper airways, and generally allows you to kind of assess the patency, so the openness of their airways. As this says, no fingers in mouths. You don't want to kind of do a mouth sweep or something like that. It could either end up, if there is something obstructing their airway, pushing it further in. Alternatively, the patient might not be particularly happy that you've put your finger in their mouth and caused you some damage. And as we've kind of addressed, we don't want to damage ourselves in the quest to help other people. So we're doing everything we can for our patients, but also for our own safety. Yeah.
So you don't want to get bitten, basically.
No, essentially. Yeah. And then we're going to be checking for breathing. So in this case, ordinarily we would be looking, listening and feeling for breath. And so to do that, I'm going to do like non-COVID rules for a second, because I think it's important that you know how to do these things in a normal society in hopes that soon we'll be back to a normal society. But essentially, you're looking to place your ear above their mouth. You're going to look down their body, down their chest. You're going to listen for the sound of their breath. Try and feel it against your cheek, and then look to see their chest move. And you're doing this for 10 seconds. Currently, I think kind of the best recommendation is if you can just look to see if their chest is rising or falling. Don't put your face anywhere near their mouth. If you're struggling with that and you can't really see, potentially place either a hand on their shoulders or like on their chest, on their rib cage, to see if you can feel it. But yeah, it's a bit trickier nowadays, unfortunately. But yeah, if they're unresponsive, you've done head tilt chin lift, you've checked for breathing and they're not breathing, this is when you're going to want to call 999 immediately for emergency support, because we need to start CPR immediately. But if they're unresponsive and they're breathing, then we'll pop them in a recovery position. And these kind of things we'll cover a bit more in coming weeks. Yeah. Primary survey.
So you'll find, just on that point, you'll find that when we do go through these sessions, we will be kind of teaching standard rules and then COVID rules afterwards. So keep your ears peeled for that. And if you're ever unsure, like, just pop us a message. But yeah, that was the primary survey. Are there any burning questions thus far that anybody has?
Probably not questions about burns. I think that was a different session.
Well, yes. Thank you, Jane.
I
don't mind.
I'm sorry.
I would take a question about burns. Why not?
Okay.
Okay.
I have one question.
Yeah, go for it.
How come you don't use the Dr. ABC, but you use this one instead?
Excellent question. So the C stands for circulation, and essentially look for major blood loss, but that's about as far as you can go in, like, as a kind of member of the public without further kind of training to assess circulation, if that makes sense. So yeah, Doctors ABC does exist, but we kind of tend to not go over the circulation bit because there's more potential for kind of assumptions to be made that might not necessarily be true. And yeah, it's just kind of not as easy to determine with someone as someone that's not got a sort of this amazing like depth of information that some people might
There's
have.
kind of a lot of guidance that comes out and changes really frequently. This is kind of one of the newer changes, is kind of stepping down, but there are loads of variations of Dr. AB. There's like Dr. A, B, C, D, E, and like it just goes on and on. But yeah, we will cover circulatory related things like major bleeding and stuff soon, I imagine. So yeah, keep your eyes peeled for that. But a really good question. Thank you.
Very good question. So yeah, if there's nothing else, we'll move on to the secondary survey. So once you've assessed for life-threatening injuries and like whether or not you need to do CPR, you can move on to your secondary survey to kind of get a bit more of an understanding as to what's going on. So it's a really like methodological, like systematic check that you don't necessarily need to do in this order, but we've got another acronym for you. So the acronym is SAMPLE. So the S stands for signs and symptoms. So that's going to be your kind of first like major, what do you notice about this patient that is really like giving you a lot of information about what's going on. So if they've got a red swollen face, it could indicate an allergy. If they've got deformities in their arm and like shouting, which might mean they've got a broken arm. Just the general kind of signs and symptoms that they might be a bit unwell. The A stands for allergies. So ask them, do they have any allergies? Do you carry an EpiPen? You know, look for clues as well. If you come across someone and they've got half a pot of tomato soup spilled next to them and they're clutching at their throat and are red and swollen, maybe think, are you allergic to tomatoes? That was a really
Thought you were going to go for a burning thing there, but hey.
That would have been a weird time to include burns, but Yeah, so ask for allergies, like do you have any allergies, do you carry an EpiPen? Medications, ask them, do you take any medications, you know, and this ties into the past medical history, so relevant past medical history, you know, has anything like this happened before? Do you kind of take any medication for this? Yeah, just trying to get to the bottom of things that might help you kind of decide what to do next and what might have happened. Last intake, so this is quite an important one for certain things that you might see as a student, actually. So last intake just means like, what was the last thing somebody ate and drank? And in students, that can sometimes be a really, really long time ago, just because they might be forgetful or whatever. So it's worth not forgetting that one, because it can be quite important. So not only what did they eat, but when did they last eat it? Because you could say, what did you last eat? And they say a sandwich, and then you ask when. It's like, oh, 3 days ago. So yeah. And then finally, event history. So this is just what's happened, how did you get to where you are now? And you don't necessarily have to rely on the patient for this. You can ask bystanders, and they're a really, really important resource. Maybe take what they say with a pinch of salt, but you know, if this person's obviously in a lot of pain and can't talk to you, maybe say to someone next to you, like, did you see what happened? Did you see if they hit their head? And just kind of getting to the bottom of those important questions that could help determine what's happened and what you need to do next. Yeah. Do you have anything else to add?
No, I think all good from me.
Awesome.
Okay. So, this one might be a bit of a long one because the head-to-toe examination is quite lengthy. So a head-to-toe examination is kind of a next step that you can take to figure out a little bit more what's going on with someone. It can be, it's kind of one of those things that you definitely won't do to every patient. However, if it's kind of more of a complex situation, if the patient can't really tell you what's going on and you really want to be able to assess and get down to the bottom of like what injuries someone might have, this is kind of your next step. Is kind of more typically done in things like major trauma, when you're questioning if there are multiple injuries or where they are and things like that. Aaron, it's a good question. Sorry, Aaron's just put examination. What is this word? And I'm very easily distracted today. Anyway, yeah. So the first stage to head-to-toe examination is to ask permission from the patient. It's quite an invasive procedure, and you want to put the dignity and kind of respect of the patient at the forefront of everything you're doing. So you want to make oh, go on.
Sorry, I just wanted to say as well, like it says, consider dignity and protect the patient, but also, you know, you've got to consider yourself in those situations as well.
Exactly. Yeah. So you're going to want to wear gloves to protect yourself. You don't want to expose the patient more than necessary. Try and get to a private place. Make sure that there's kind of you and someone else around. And you definitely don't want to move the casualty more than needed. So if you can clear the area, that is ideal. So in terms of actually carrying out the head-to-toe survey, you want to start at the head. Crazy, I know. So you're going to run your hands kind of over the scalp. You're going to feel for bleeding, any swelling, tenderness, things like this, and any potential like depressions in the bone of the skull. You really want to be careful that you aren't really moving their neck, because neck injuries are kind of normally quite unstable, and you want to be able to stabilize that before you're doing anything particularly crazy with the patient. So just kind of simply running your hands over the head to feel for those things. Look at your gloves afterwards, make sure there's no kind of blood on them or anything like that. And then from there, kind of looking in both ears, making sure there's no bleeding, no kind of clear fluid coming out of them, which would be like cerebrospinal fluid and not great. So hopefully you won't come across that. But something like kind of fluid coming out of the ear is a sign of quite a drastic head injury, which again isn't particularly ideal, and we will be going over head injuries at a later date. you're then going to do this kind of all incorporates a lot of our observations as well. So at this point, you can check pupils. We'll go into that in a moment. So I will hold off talking about that. Yes. So other things you can kind of have a look at: nose for any discharge, any bleeding, clear fluid, things like that. Mouth for any obstructions, or if they have like damage to their teeth, things like that. Skin, so are they pale, are they cyanosed, so bluish, are they flushed? And then it's a case of kind of going down the body. You're going to be using the backs of your hands to compare both sides at the same time. So you can run your like the backs of your hands down their chest, make sure that everything feels normal, down their arms, make sure that both sides are the same. If they're not, ask the question, is this normal for you? Because some people have had bad breaks in the past, they have metal in them, it might just not feel the same, but you want to know if you're in a dangerous place or not. Yeah, so shoulders, upper arm, elbows, hands, fingers, making sure everything's good. And then you're going to be checking kind of hips, legs down to the toes, making sure that they have sensation, things like that. Everything's symmetrical, everything's normal. I talked a lot right now. Go down their body, make sure everything's the same. Yes. I'm sorry, I ramble.
It's all good. But you mentioned a key thing there, which was ask them if things are normal for them, which I forgot to say when I was going over samples. So it's a really, really important thing. If you notice something that doesn't look quite right, make sure you just ask, like, oh, is this normal for you? You know, especially when we get onto pupils as well. Just saying, is this normal for you? Because it might be that actually, yes, they've got scoliosis, so they do have a bit of a deformity in their back that, you know, you've noticed when doing this assessment, that actually doesn't indicate much harm. And the same goes for like lumps and bumps on arms and legs, people bruise, you know, it might be that that's normal for them and that it happened when they were much, much younger or whatever. So just asking that question is a really important stage. So yeah. I think that's the
just while we're here, Elizabeth made a very good point in the chat about medical ID bracelets and stuff.
Yes.
That might be something that you would check in the kind of M part of the sample algorithm. So no, sorry, in the P part of the sample algorithm, in the past medical history. But if you haven't checked already and you're doing a head to toe, it's something to watch out for. It's kind of, the conditions vary, but I'd say probably the most common are diabetics and epileptics. But of course, there are people who have medical alert bracelets for a vast variety of different things, but they're always good to keep an eye out for.
Definitely. So just checking the context around you as well, and the clues that might be around you, because some people, it's not on their wrists either. Some people wear the like dog tags.
Yeah.
I just thought of something else as well, I can't remember. People have them on their keys. So if you are putting someone in, say, the recovery position or doing a head to toe examination, you find keys, it might just be worth seeing if there's something on that. I know some people carry their like blood type on their keys and stuff as well, so definitely worth kind of looking at not just the patient but what is around them.
Yeah, I think that also on the phone, if you try and do the emergency call function, it will pop up.
Yes.
I don't know if that was said. But yeah, that's something that like more people tend to do because you don't have to go out of your way to buy something. So like I think I've got like something about mine on there, even if it's not particularly relevant.
Yeah,
but
that's an amazing point actually, and I don't actually think that's come up at all this year in first aid. So well done, Jay. Yeah, I think Apple phones, it's really easy to find. I've not been able to find it on my Android, but a lot of people do have an emergency number on their phone. So if, say, like, obviously start with the treatment of the patient, but if there's a bystander, say, you could pass them the phone and say, like, look, have they got an emergency number on there? Obviously being careful that you're not just handing this person's phone away, but yes, definitely a good point.
So it should work in the same way on Android to get to it. If you like try and log in, but obviously don't because you don't know their password, there'll be a button that says emergency, and then normally something in red that says like emergency information. and that should work.
Awesome.
Yeah, amazing. I had another quick point on like, my brain is just failing. 1 second, words. In terms of like medical bracelets and things like that, another thing you can look out for is like medical devices. So for example, like somebody with diabetes might have like an insulin pump or continuous glucose monitoring device that are kind of like implanted in their skin, and if they don't have kind of a medical bracelet but they do have one of those, it's a really good kind of indication of what's going on. So there's kind of another thing that you can look out for that will give you a bit more a few more clues as to what's going on. So yeah, cool.
So that's a lot of information that we've just gone
a lot
through.
of tangents. Things like
Yeah.
that. I'm sorry.
Are there any questions or anything before we move on to observations?
I was just going to say, you ask for permission, and if they're unconscious, what do you do?
It's a good question. So if a patient is unconscious but breathing, we are kind of doing everything we can to act in their best interest, even if they're not breathing. I don't know why I added that side note. So acting in their best interest, we want to kind of maintain or improve their state. If they are unconscious, then you can carry out a head-to-toe survey, but a really important thing to note is to talk through it even if they aren't conscious. So you're not able to get kind of consent for it, but if you're acting in their best interest, that's what's important. So yeah, that's kind of what I would say there. Make sure that you're keeping their kind of dignity paramount still and giving that explanation, because you don't know what they can hear and kind of what is going on. So
Yeah, amazing.
What I would say on that.
So observations. I think if we did go over this in freshers, it was very quick. So hopefully this is some new information for you all. But we take observations to, as it says, to identify problems, indicate changes in a casualty's condition. That's the really important bit. It's what Beth was saying earlier about the response level. So if you're continuously monitoring observations, you can tell if someone's deteriorating, if they're getting better. You know, it's the easiest way to kind of say, oh, okay, this is getting a lot worse, we need more help, or, you know, we need to do this next. So as part of the primary and secondary survey, there's some key observations you should try and take. So the pulse rate, respiratory rate, capillary refill, and temperature. I think I actually have added a couple more on the PowerPoint as well.
Yes, you have.
Beth, do you want to take it away with pulse rate?
I would love to. Okay, so pulse rate is kind of one of the kind of things that you think of when you're thinking about observations. I will quickly go over how you take it first and then do the numbery things. So there are lots of ways that you can take a pulse. There are lots of places you can also take a pulse. So the kind of most common, I would say, is the radial pulse. So your radius is on the thumb side of your hand. And then with three fingers, if you just kind of place your fingers to the outside of the weird tendon, normally you'll find your pulse. Don't place your thumb, because otherwise you might feel your own pulse instead of the patient's pulse. But yeah, thumb side of the hand there. You can also take a brachial pulse, which is found kind of in the crease of the forearm. I personally find a brachial pulse really, really hard to find. I would rather do a radial or a carotid, which is in the neck. So again, kind of to the side of the neck, 3 fingers, don't use your thumb. In theory, you'll find a pulse. Yay, I have a pulse. That's always good.
Yeah,
and
try on yourselves at home. Go ahead.
Yes,
and
please feel free. Yeah. And then in terms of children or like infants, it's normally best to take a pulse. Is it a brachial pulse for a child?
Yeah.
Is that why we have a brachial pulse there? That would make sense. Yeah. So kind of in the crease of the forearm there. You can also check kind of on young children. If you can't really find a brachial pulse, you might be able to find a femoral pulse, which is kind of in their groin, but also in terms of our like dignity things, that's a little bit of a weirder one, but if you need it, try, you know. In terms of usual parameters, pulse rate really changes based on kind of who you're doing it on. Infants have a really fast pulse rate naturally, so 110 to 160. A child can be from 80 to 130, and an adult 60 to 100. These are kind of very vague parameters. Obviously, children is quite a vague term as well. That could be anything from kind of 1 plus to, 12 or 16. So kind of use a little bit of judgment there. But yes. And in terms of adults, some people naturally have kind of faster heart rates. Some people have naturally slower heart rates. It can depend on a lot of factors. If somebody is kind of like a triathlete and goes and does insane exercising every day, they're probably going to have a lower pulse rate than the average population. And that might be normal for them. So again, asking those questions, is this normal for you? Do you know what your pulse rate is normally? Is a pretty good question to ask. We're also checking at this point for rate, strength and rhythm. So rate is those parameters we just spoke about. In terms of strength, is it weak? Is it thready, we like to call it? Is it bounding? There's kind of lots of ways that we can assess the strength and rhythm of a pulse.
Strength-wise, you could almost go as like, when you found it, is it obvious that it's there kind of thing?
Yes, exactly.
If you're kind of like, oh, I think I can feel a pulse, but I could be wrong.
I'm not quite sure.
That person has a really weak pulse.
Yeah.
And again, for that one, look for other clues. If they've got a really weak pulse and you're also laying in a pool of like their blood, then that's probably why they have a weak pulse. So you can look for other clues as well.
There's quite a lot of reasons why the strength of a person's pulse can change. It changes based on like heat-related illnesses and shock, which we're going to do a session on soon. So we'll kind of go a bit more into when you would expect that to change, but for right now, just be aware that it's something that we assess. Yes.
Yeah, so when you're taking the pulse, ideally you can take it for a minute.
Say for how long? I'm so sorry.
It's all good. So ideally take it for a minute, because then you can count them. Like, you don't have to do any multiplication if anybody is really afraid of maths, which I am a lot of the time. So yeah, you can take it for a minute. Minimum you want to take the pulse for is 30 seconds, so that you're only timesing it by 2. If you take it for 15 and times by 4, you might lose some of the accuracy. It's not, if it's an irregular pulse, you might not notice in that time frame. So aim for 30 seconds, and if you can, take a pulse for 60 seconds. And don't count seconds on your watch. Very important. Don't do that. If you come up with 60, maybe it's 60, but also maybe try again.
Yeah. I think another thing to say, sorry, really quickly on that note, is if you do it for kind of 15 seconds and then it's quite abnormal, do it again for longer and just make sure that it is abnormal or not.
So respiratory rate is very difficult to take. And I think even those of us that are like first aiders with St. John would tell you that it is quite a difficult one to take. So respiratory rate is just how many breaths you take in a minute. And the usual parameters are there. So again, faster for infants and children. In an adult, the range is really small for what's classed as like normal and good. In reality, again, use context. If you come across someone that's just run a marathon and their resp rate is like 18, that's also fine, probably. So continue to monitor it, but don't just say, oh my god, it's not within 12 to 16, they must be dying. But equally, those are the kind of parameters that we go by. So when you're taking respiratory rate, you're also going to want to listen. So look out for the rate, the depth of their breathing. So are they able to breathe really deeply, or is it actually really shallow breathing, which could be an indication of something going wrong? The ease, so if they're finding it really difficult, so asthmatics and people with hay fever and things might find it quite difficult to breathe. Same for allergies. And noise, so if you can hear like crackling or wheezing, they might also have an issue. And that's one to ask if it's normal for them as well, because it might be that some people do have a wheeze when they breathe. But yeah, so those are the things you're looking for. The easiest way to take your respiratory rate is to place your hand on the person's shoulder and just feel for their breaths. However, you do this and someone will start breathing differently to how they normally breathe if you've told them, I'm just going to check your respiratory rate. So be careful with that one. It might be that while you're taking pulse, you watch if you're able to take 2 counts at once, which can be quite tricky. But yeah, if you're really, really struggling, hand on the shoulder is the easiest way to tell. If you can do it by just observing, then do. Guys, obviously be careful when you're doing this on women, because it can just look like you're staring at their chest, which isn't great. But yeah, that's the general overview of rest breaks. Again, a bit of a tricky one, but you get the hang of it. So,
capillary refill. Yes. So capillary refill is a kind of measure of peripheral circulation, or circulation in general, depends where you do it. Yeah, my brain's not with us currently, apparently. So to check capillary refill, normally we do it on a finger. So you would press down on the person's fingernail until it goes white. And then when you release up, you're counting how long it takes for it to go pink again. I've just realised that I have really terrible capillary refill. I'm so cold. So you're looking for that colour to come back within about 2 seconds. As I've just said, I have terrible capillary refill at the minute because I have really cold hands.
My fingernails are currently blue, so...
Yeah. That's a pretty normal thing when you're cold, for your capillary refill to your fingers to just be slower because your blood supply is diverted to other places. Yes. So we can also kind of check capillary refill in other places. So kind of the forehead, you just press down until it goes white and wait for the colour to come back. Yes. Delays longer than 2 seconds can indicate impeded blood flow. And then we have some nice pictures demonstrating it on some different coloured skin tones because we like learning. Yay.
Yeah.
Oh, a note. Capillary refill is a really important thing to do when you're bandaging someone, which I think is what Becky was probably about to say.
It's not actually. I was going to come up with a story time, but you're right.
Oh,
it's
okay.
very important. Bandaging and slings, basically anything where somebody's blood flow may be impeded, check cap refill. Yeah. So
Are we getting a story time?
We are having a story time. We're getting a story time.
I'm so excited for when we do fainting as a topic. I have so many. It's going to be great.
You have lots of stories, but I'm excited to hear them. So, capillary refill. I did some work experience in a Tanzanian hospital a few years ago, and
so cool.
There was a group of 4 of us that were like these tiny little, 16-year-olds, didn't have a clue what was going on. Nobody was speaking English. This doctor comes up to us and he's like, "Do you guys know what capillary refill is?" I was like, no. And then he just bashes his thumb into all of our foreheads and he's like, "There it is." And it was really frightening, very concerning, but we know what capillary refill is now, so there you go. That's
incredible.
Story time.
And it just violently pokes forehead.
Yeah, it was really concerning at the time. So,
can you imagine?
That was cap refill. Temperature, a big one at the moment. Yeah, hopefully you all know what the usual parameters for a temperature are. Between 36 and 38 degrees. 30, is it? Is that correct? I'm second guessing myself because 38 seems high.
No.
On the News 2 score, I think that's what it is.
Okay, right. So between 36 and 38. Higher than 38 is bad and will indicate fever. At the moment, we don't want that at all. Lower than 36 is also bad because it could indicate that you're too cold, which isn't great. So they also, not only can they indicate problems with the body, but can lead to, like, being that hot or that cold can lead to, like, permanent damage because your organs start doing funky things. So yeah, it's really important to, we'll have a whole week on temperature at some point, but
we're promising a lot of sessions this session.
Just to say quickly that the COVID temperature is 37.8 Celsius or higher.
I thought 38 was high.
37.8.
Yes. So hopefully you all have a digital thermometer, and hopefully they'll work. I was given one that didn't work, which was mildly concerning. But what it should do is when you press the button on the end, it'll beep, and then you put it in your mouth for, I think they suggest a minute, don't they? And then, so it wants to go under your tongue, and that's quite important. If you just whack it in your mouth, it might not be as accurate. So under the tongue if you can, for about a minute, or until it beeps again. I believe these ones beep again that we've been given by the uni. And then it will just say your temperature on the screen. So then St John Ambulance and other like medical professionals and all that jazz use tympanic thermometers. So these are the ones that you'll get stuck in your ear. And they work in a really, really similar way, but all you need to do differently is just pull the ear back, and that's really important. If you can't see into the ear canal, that probe isn't going in the ear canal either. So pull the ear back quite firmly, and then whack it in the ear, and then it will beep when you press the button, and then it will give you a temperature. So yeah, that's temperature. Again, you know, if it's too low, maybe give them like, if you've got anything warm, give that to them with a foil blanket over the top, and then that heat will all kind of radiate about in there. And if they're too warm, try and kind of emulate sweat if you can. So if you can, keep on like sort of splashing cold water on them, taking off layers of clothing, all that jazz. Yeah, so the FAST test.
Cool. So the FAST test is a way to assess kind of whether you think someone is having a stroke or not. So a stroke might be recognised by facial weakness, arm weakness, speech problems, sudden loss of vision, sudden confusion, or a sudden headache. So essentially, a stroke can kind of come in two forms. I'm going to do a really brief overview here. You can either get an ischemic stroke, so that's where there's a blood clot in the brain, so it's preventing blood from getting to areas of the brain, or you can have a hemorrhagic stroke, so there's a bleed in your brain. So the brain's pretty clever. I don't know lots about it, but from what I understand, half of it does half of the body, half of it does the other half of the body. And so when you get damage to the brain, we have psychologists here and it's just stressing me out. I don't do brains, I do bones. So when you have damage to the brain on one side, you kind of see the effects of it on the opposite side of the body, which is why we have these kind of one-sided symptoms that come on. So the FAST test is just a quick little acronym, hey, another one, which lets us kind of assess these things. So F, face, do they have like a facial droop on one side? Arms, ask them to lift up their arms, make sure that they're both kind of doing the same thing. Speech, ask them to say a sentence or something. Kind of, oh, Aaron, what was your sentence that you used to test people with?
What?
Didn't you have just like a dumb phrase that was just really hard to say?
I would no, for stroke I get them to say a complicated word, so I normally go with hippopotamus.
Was it? Yeah. I was trying to work it out. I was like, I'm sure Aaron had something that just... Yeah,
it works quite well because you have to use your mouth quite a lot to make all of the P's and the H, and so if they are having like motor issues in the face, then it's hard to say that word.
That makes sense. There we are, hippopotamus. So yeah, ask them to say something, assessing whether they have slurred speech, whether they're able to kind of make the sounds that they're trying to make. And then T is time, which is really, really critical in patients with strokes. If they can get treatment, they can return to pretty much normal function as long as it's kind of quick enough. So if you recognize any of these symptoms, call 999. They need to go to a hospital. They need to be treated as soon as possible. I had another point I was going to make and I've just completely forgotten it. So I'll just leave it there.
Yeah, so I have a couple of things to add. This is a very important one where you ask, is this normal?
Yeah, that was my point.
Because there's some syndromes such as Bell's palsy causes a facial droop, and you know, sometimes if someone's say like hurt their arm in the past and they don't have function in one arm or whatever, like there are things that might mean and that could explain sort of reasons that someone's having these symptoms. So don't just immediately be like, nope, don't tell me anything else that's like that might be the cause of this. I'm going to call an ambulance straight away because you're definitely having a stroke. Make sure you check for those things, you know, kind of get to grips with it. Sorry, I just had to get a blanket because I was really, really cold, so sorry if that's distracting. Anyway, and also with arms, so I was doing some training last night and somebody asked me a really good question that was like, if I've just put someone in a sling, how do I get them to raise their arm to do fast test? So what you can do is just try and get like a vice, like kind of just any kind of grip that they can get on your hands. So I don't know if people can see me, but you know, if they can't make a fist, which they might not be able to do if they've broken their arm, because that might be really painful, if you just put a finger between two of theirs and get them to squeeze, it's still that like gripping, that kind of like motor action that kind of you will be able to tell if they're able to make that gripping force, even if it's not making a fist or raising their arms or whatever. Just that kind of subtle movement and that subtle grip can be an indicator that it's not an issue, or that it is an issue. So yeah, so long as you're trying to get them to do the same thing with both arms, then hopefully you should be able to tell what the differences are.
Amazing. Yes.
Okay, so I'm seeing lots of, like, the thing keeps, I can't see the chat, but I see lots of things are happening in the chat. So if there
it's mainly about temperature and thermometers, don't worry.
Okay.
Yes, we're having a discussion about different types of thermometers,
and how, in certain ways in which you can use them.
Yes.
Right.
Yes.
Okay.
And
don't worry too much about it.
Yeah.
I'll let you know if something kind of comes up that we haven't addressed.
Awesome. Okay. Pupils. So I was really slow with animations this week. I do apologize, guys. That will get better, I promise. But pupils, we use, I don't know, this isn't an acronym, is it? Is it an acronym? I don't know. We use a word that might be some.
It is pupils equal and reactive to light.
Yeah, but in my head, because it makes a sentence, not a bunch of words, that's not right. Oh, it's been a long day. Okay. Yes, so you want your pupils to be equal and reactive to light. You might just be able to remember that, but if not, use Pearl. That can be a really quick way to do handover as well, just FYI, small side note. I've got a video to demonstrate this because I didn't want to, showing people on camera would have been difficult. From the photo, yeah, from the photo on the side, you can see that you've got normal pupils, dilated pupils, and I didn't get a photo, but there's pinpoint pupils as well, which can also happen. So that's just really, really tiny, tiny pupils. And then the final one is something called anisocoria. So this is a condition that is permanent. So some people will just have pupil sizes that are different in each eye. Again, ask them, is this normal for you? But if that isn't the case, and if it's not normal for them, that's bad. That could be a sign of a head injury. So without further ado, I will show you this video, and I'm gonna stop sharing and then restart sharing, I hope. Oh no. Yeah, okay. We're getting there.
We counted 4,409 individual pieces of plastic just used by one person. And of those 4,409...
This is not a ambulance video.
This is the pupillary response. It can give you a lot of information. We can tell you about the patient's neurological status as well as any potential drugs that are on. First, assess the diameter of the pupil. Here, it's about 6 millimeters. Use the light, flashing it into the pupils and looking for it to constrict. Also note, when I flash into one eye, both eyes will constrict. And that's assessment of pupillary reaction.
So, hopefully, you all saw that. The brightness might not have been amazing, but yeah, that's how to assess pupils. So like you said, You want to check the direct response by flashing the light in the eye and looking at the eye that the light's in. And then you want to check the indirect response, where you want to check the opposite eye to the eye that the light has just gone into. So hopefully you all saw that with that one, that the indirect and the direct were both equal. It was all, they were all constricting and dilating at the same time. So that's pupils. I'm trying to think. I just thought of something about his video. But anyway, yes. Is that the end of? Yeah. Okay.
Yeah.
That's the end of what we had to say. Key takeaways. Oh my god, my flatmate put this in and I forgot to take it out. I'm sorry. Key takeaways. Yeah, we like Chinese and Indian and Thai takeaways. Can be quite nice. But the primary survey, do it first to assess for life-threatening conditions and prioritise treatment. Use the secondary survey to assess for other injuries, and then take observations to notice any change in a condition. Hopefully you've all learnt those things.
Thank you for watching our video recording of this EUFAS session on primary and secondary survey. We hope you found it interesting and informative. If you'd like to learn more, please do join our next sessions, which can be found advertised on our Facebook page, found by searching Exeter Uni First Aid. Thank you.